Okay, MG. This is an autoimmune disorder. What do we mean again? We started with an autoimmune disorder, two of them last week. So we had Hashimoto and Graves' disease. So what is the nature again? Okay, so do we know what causes it? No idea. Right. So this is another sad disorder wherein we don't know what's causing it. So is there really a cure? No, we can only treat it though. We can treat it symptomatically, keep the disease in remission. As with any other autoimmune disorder, lupus, MS, myasthenia gravis, rheumatoid arthritis, these are our goal since they're chronic. Our goal is to put the patient in remission, remission meaning symptom-free for as long as possible. That's the goal. Because it's autoimmune, what will the treatment involve? Immunosuppression. Okay. We'll get to that because not everybody's treated with steroids. Okay, typically we reserve steroids for exacerbation episodes, meaning the patient has an acute attack of that chronic disorder, that chronic autoimmune disorder. Then we can use steroids for a short period of time. So what exactly happens in myasthenia gravis? So I'll get to this illustration here. So we'll use this as our discussion. So if you review anatomy and physiology, so how our muscles move. So let's say I'm going to pick up this eraser. Okay, so I thought about it and I'll pick it up. It was a smooth action, right? So I thought it, I picked it up, I was able to do it. These patients won't be as smooth because what made me able to do that was two things. So I needed acetylcholine. Acetylcholine are neurotransmitters, meaning they travel from one neuron to the next, and that travels all across muscles. Okay, so that enables me to contract the muscles. However, during the transmission, as they move from one neuromuscular junction to the next, they have to be received. This is lightning fast. Okay, so it goes from one microscopic neuron to the next lightning fast. So you have acetylcholine here. Here, these are the acetylcholine, these round circles here. And then you have receptors. Something has to receive them from one neuron to the next. Okay, so you have, at any given time, you should have an equal number of acetylcholine and acetylcholine receptors. Okay, so just like, let's say, the Midtown Tunnel. Okay, so there should be enough room for cars to pass through, right? For smooth traffic. So similar idea here. So if you have enough acetylcholine and enough same number of acetylcholine receptors, then the transmission of those impulses will be smooth. So my action of picking up this eraser is smooth. All right, so that's how it should work. The problem in myasthenia gravis is there's enough acetylcholine, no problem with the number of acetylcholine. What was destroyed by the antibodies are the receptors. So on the left picture, on A picture, that is the normal neuromuscular junction. On B, you see here there's not enough receptors anymore, right? So some of the receptors have been destroyed. So therefore, is there a mismatch now between acetylcholine amount and the amount of receptors? Yes, there's a mismatch. So therefore, can transmission be smooth? Can I sustain a muscle contraction? No. So particularly, the problem here is, yes, I can move, but I cannot sustain that movement because there is a mismatch. So I cannot sustain repetitive movement. So if I perform repetitive movements like walking, what else are repetitive? Chewing, right? Swallowing, those are repetitive movements. Blinking my eyes, that's repetitive. Talking, breathing is repetitive. So therefore, with repetitive motions, can I sustain them for a long time? It will result in progressive weakness. So anything I do, if it involves repetitive muscle contraction, I cannot sustain that. So I will have weakness as my very common manifestation. So let's go now to the testing. So how do I know? We already know the risk factors. I mean, we don't know because this is autoimmune. So I would say risk factors. Well, if you have autoimmune disease in your family, well, you could possibly develop this. We don't know. So testing, how do we know this is what you got? So let's go to, well, the manifestations are here. So let's start with manifestations. So again, they are involving weakness with repetitive muscle movement. When you rest for a while, then you regain the energy. But then as soon as you repeat the movements, the weakness occurs again. You understand? Okay, so that is every day for the rest of your life, right? So these are the most common manifestations. Again, all of these involve what? Anything repetitive. So blinking your eyes, is that repetitive? Yeah, we're not aware, but we actually blink our eyes how many times per minute? A lot of times. Okay, so there will be double vision, or what do you call this? Drooping. Okay, there will be drooping of your eyelids because you're not aware, but you actually blink several times a minute. So that will be one of the common manifestations. So ptosis is drooping of the eyelids, diplopia, double vision. Okay. Here, bulbar muscles. So bulbar muscles are those involved in chewing, swallowing, speaking. Okay, the muscles around here, facial, maxillofacial muscles. We call them collectively bulbar muscles. So therefore, will this patient also complain of choking? Yes, because when they eat, that's repetitive, right? So can they eat through a meal? Normally, no, they have to stop. Yeah, I'm tired. Yeah, and then and sometimes, right, and then when they swallow, sometimes they choke because there's this coordination, okay? Because each weekend, I can't finish a meal, right? So they take a long time to eat. So there's dysphagia, difficulty swallowing. Again, choking is common. And then just generalized weakness, intercostal muscles, because there's the diaphragm also repetitive. Yeah, we have to breathe 12 to 20 times a minute. Okay, so that muscle is repetitively contracting, so that weakens as well. And that will be the same. So can this patient walk normally? They'll have to stop every few feet, okay, because they're tired. So they'll rest and then, okay, I'm ready again, wait, get up again. And then a few meters later, no, they have to stop again, okay, because they're weak. Let's go to the assessment. Now, when the patient manifests with these manifestations, the doctor, of course, based on the uniqueness of the set of symptoms, involves weakness, they'll do what's called the tensilon test. Okay, your symptoms seem to be those of myasthenia gravis. So let's see if this is what you have. So what they'll do is give you, oh, I forgot something back here. Let's go back to the figure. In the process of the nerve impulse transmission, because this is continuous, right? So we have acetylcholine, and then we have receptors that will receive them, nerve transmission. How do we stop the muscle contraction? Something has to stop it. So we have a substance called anticholinesterase, which will destroy acetylcholine, meaning allowing us to stop the muscle contractions, because otherwise it will never stop. Okay. So as long as all of these are balanced, you have acetylcholine receptors, and then you have anticholinesterase, which will destroy acetylcholine, everything's functioning well. Okay, as long as all three are working together. Now, during testing, we will give you an anticholinesterase agent, or also called an anti-acetylcholinesterase inhibitor test. Okay. The drug we use is called hydrophonium chloride. Now, this drug is an anticholinesterase. However, it's only short acting. This is only used, therefore, for testing purposes. We cannot use this drug to treat the patient because If it only lasts for a few seconds, I mean, how much of this drug do you have to take? Every minute you have to take the drug, right? This doesn't make any sense. So it's only used for what? Only testing. Okay. So the first scenario is you've never been diagnosed, correct? So this is the first time you came to the doctor, meaning you're not taking this drug at all. So you came in with the symptoms, then the doctor will say, okay, let's do a Tensilon test. Tensilon is the brand name of edrophonium. So that's why it's called Tensilon, Tensilon. So what they'll do is it's IV. So start an IV access, give it to you. 30 seconds later, your strength improves. Okay, you feel a burst of energy. Okay, you can sustain muscle movements. Oh, my symptoms got better. What'd you do, doctor? Okay, so if this is the result, meaning there's improvement in the muscle strength, then it is a positive Tensilon test. So they'll say, oh, your symptoms improved, you have myasthenia gravis. And then they'll prescribe you a long-acting anticholinesterase inhibitors. Or no, sorry, anticholinesterase agents. Okay. Any question? In the third world, we have a poor man's Tensilon. The doctor, of course, it's not really that reliable. So the doctor will ask you, okay, can you do this for me? Okay, can you blink your eyes repetitively? So if the patient blinks their eyes and then eventually stops, can't do it anymore, then our doctors will say, okay, that's a positive poor man's Tensilon. Okay. Of course, that was when I was going to school. Okay. Now we can afford Tensilon. Okay. No. We won't test the other diagnostic testing. Plus, what does this say on the paragraph? Is it really specific to myasthenia gravis? No. Other tests can be done like EMG, RNS, but they're not really diagnostic for myasthenia gravis. So the reliable test is the Tensilon test. Will the other test be done? Yes, but only for purposes of ruling out other potential causes. So let's say if they do a EMG, it's positive, they'll say, oh, your EMG is positive. This may be a spinal stenosis problem, meaning it's a spinal cord problem, a spinal nerve problem. All right, so that's why they do the other tests just to make sure they don't make a wrong diagnosis. All right, but none of them confirm myasthenia gravis. What test confirms myasthenia gravis? The Tensilon. Okay, we'll go back to the Tensilon test later when we get to the complications. The last paragraph here is talking about the thymus gland. Now, only about 10% of people with myasthenia gravis have a thymoma. What is a thymoma? A tumor in the thymus gland. Where is your thymus gland? Right here, okay, in your sternal notch, right here at the base of your throat. The thymus gland is involved in what? In antibodies, part of your immune system. So they believe that if you have a tumor there, that could be what's causing producing the autoantibodies. Okay, that tumor growing there, and then that's what's causing you symptoms. But it's only a very small percentage of people with myasthenia gravis. So not all will have a thymoma. All right, but they'll check it anyway, because you could be one of those small population that has a thymoma. And if they remove that, meaning you have a thymectomy, they remove that. Sometimes it's successful, sometimes it's not. Management. Since it's autoimmune, is there a cure? So what's the treatment for? The symptoms. Okay, so to put you in remission. All right. So the management would be the following. So we can give you immunosuppressants, or what we call also immunomodulating drugs, immunomodulation therapy. Right here, immunosuppression. and then we'll give you anticholinesterase medications. Now, the IVIG is the most expensive among these because immunoglobulin is sold per gram. It's an IV infusion. It's basically antibodies, okay? So good antibodies. It's sold per gram and it's based on weight. So let's say if 1 gram costs 1,500 bucks and let's say it's 1 gram per kilogram, how much are we spending here? Tens of thousands of dollars per infusion. Now it's not one infusion. It's going to be a series of infusions. All right, so it's quite expensive. So we reserve that only for severe cases, okay, but not for everyday treatment. Okay, unless of course you're rich, then you can afford this. Okay, fine, pay out of pocket. A cheaper alternative is therapeutic plasma exchange, which is, you remember dialysis? Okay, so in plasma exchange, it's like dialysis. So you'll need IV access. No, two. So we'll take blood out of your body, put it through a machine. What are we doing? We're another term for a therapeutic plasma exchange is plasma pheresis. So what does that do? The machine, instead of in the dialyzer, what did the dialyzer do in hemodialysis? It removed fluid and electrolytes and waste products, right? So an apheresis machine used for plasma pheresis will remove antibodies, will remove the patient's bad antibodies, and then give them somebody else's plasma, which doesn't contain autoantibodies. That makes sense? That's why they call it plasma exchange. Why does this work? Because what's causing the patient's symptoms? Those bad antibodies, those autoantibodies. So the machine will remove the patient's antibodies because they're no good, give you somebody else's good plasma. Does that make sense? All right. No. Thymectomy is the surgical removal. Okay, so these are, again, the options. Remember in hyperthyroidism, we had options, right? We had surgery, we had radiation, we have anti-thyroid medication. So here, these are the options. So we can use anticholinesterase medications. We can put you in remission using immunosuppressants, can give you IVIG or plasma exchange cheaper, or surgical removal of the thymus gland if you have the tumor. Any question? Yes, correct. But not forever. Okay, so a few treatments at a time. Again, there is no cure for MG.
They also put on a fistula.
Yes, if you have therapeutic plasma exchange, or they'll use a catheter if they want it right away. So again, treatments do not stop production of the antibodies. Are we clear? So none of these is a cure. Are we understanding each other? All right. So this will keep the patient alive though. It keep them in remission. So let's start with the drug therapy option. So they mentioned anticholinesterase agents. So the drug most commonly used is pyridostigmine bromide. This is the cheapest option. This is the first line therapy. Patient will be taking several doses a day. Now the dosing won't be the same for each patient. It really depends on, well, what do you do? Kind of patient is this? Is this an old patient, meaning, pretty much retired? Or is this a young patient? Young patient who will therefore require higher doses, an old or a younger patient? Older patient will require higher dose?
Oh, no.
Okay, the younger, because the younger people are more active. They have more things to do. Okay, they walk, they're working. Whereas a retired person, what is this person doing? Yeah, fishing, right? Fishing, maybe playing some golf. Okay, not really that active anymore. So therefore, the dosing will depend on patient's activity level. Here's the maximum
And we
Uh,
monitor the acetylcholine level.
we have to, yeah, periodically, we will watch the patient's acetylcholine level, because two things can result here. Because the dosing changes, okay, because let's say you're running a marathon, will you take the same dosage? You'll be taking higher doses. So some days when you're not working, will you be taking more doses? No, you'll be taking less. Does that make sense?
Mhm.
Okay, so since the patient constantly changes the dose depending on their activity level, could it be possible that they'll take too much or not enough of the drug? Yes, either case will result in a crisis. We'll talk about that toward the end. Now, if this patient ever gets hospitalized and can't take the pyridostigmine, because this is PO, there is a IV form for neostigmine. So just remove the pyridose and then pyrido, and then change it with neo, NEO. That's the name of the drug. That drug comes in IV. You follow? Okay, so if the patient can't take it by mouth, then they will be given neostigmine. Okay. So here, if the patient's symptoms persist with anticholinesterase therapy, then we'll start immunosuppression. Right? So patient will be given, there are a few here, azathioprine. Do they sound familiar? Okay, oh, we haven't talked about. Okay, azathioprine can also be used in MS, also in rheumatoid arthritis, because what's the nature of these diseases again? Rheumatoid arthritis, lupus, they're all autoimmune. So therefore, can drugs be used across all of these? Yes, so they can be shared among other autoimmune disorders, right? Steroids, again, is only reserved for an acute exacerbation, meaning patients having an acute attack will give them steroids. Why? Is because steroids broadly inhibits everything, meaning if you're given steroids, they're not cell specific. They won't just choose, which immune system cell they're going to inhibit. They'll inhibit all of them, right? So therefore, is it wise to use steroids all the time? No, only for acute exacerbation. Because do we need to suppress the entire immune system? No, they're not all responsible for the patient's symptoms, right? Only select types of immune system cells. So it doesn't make sense taking steroids every day for the rest of your life for this kind of disorder. So we'll only reserve it for an acute exacerbation when we want the patient to feel better quickly. So we'll give them steroids, high dose steroids for a short period of time. So again, only reserved for acute exacerbations, acute flare-ups. So these are the immunomodulators, the cytotoxic medications. Azathioprine, the brand name is Imuran. This is pretty popular for autoimmune disorders. Because they're immunomodulators, meaning they suppress the immune system. So what's the side effect? Bone marrow suppression. So you've got leukopenia, which means low WBC count, and also liver toxicity. So we need to monitor blood work, especially liver and CBC. So liver enzymes and CBC will be monitored. So here's IVIG. If again, IVIG and therapeutic plasma exchange is reserved only for acute exacerbations. So you come in for a flare-up, they'll consider IVIG or therapeutic plasma exchange. Notice I said or, okay? You can't have both because it's redundant. IVIG is just as effective as therapeutic plasma exchange. Same effect. However, which one is cheaper? The plasma exchange is cheaper, but the effect is exactly the same. The IVIG, however, since it's more expensive, it also has less side effects compared to plasma exchange. Speaking of which, let's go to plasma exchange. This is the effects. So it tells you here effects of IVIG only last 28 days after infusion. And these are the complications. You get a headache, migraine, meningitis, which is rare, flu-like symptoms. Because again, what does the drug do? The infusion do? Okay, so are all your antibodies bad? No. Okay, so the consequences would be you get more sickly. Okay. And here are a few drugs that cannot be given together with that IVIG. Let's go to therapeutic plasma exchange. So what does this this procedure do? So I described it just like dialysis, right? Only the difference, what is it? What is the machine removing? Plasma, okay, plasma. So because plasma contains antibodies. However, what else is in plasma? Because you're removing all the patient's plasma and giving them somebody else's. So what else is in plasma? No, just plasma. You said it's water, right? 70% water. It's 20 something percent protein. And the rest are clotting factors and antibodies. So you removed all four. You removed water, protein, clotting factors, and antibodies, which are comprised of good and bad antibodies. The machine won't discriminate, okay, which antibodies, because the machine will remove plasma. It'll take out all the plasma. So all the good and the bad are removed. So what could possibly go wrong if you lose plasma? What happens to blood pressure? Drops. What happens to your ability to clot? It could be bleeding problems. What else? Can you get infections? Yes, because we removed everything, good and bad antibodies. And what else? Do we have also citrate problems? Because what did we describe again with blood transfusion? No, because the blood is removed, right? Comes out of your body, goes to the machine, then returns to you. What is the substance used to prevent your blood from deteriorating or clotting while it's outside? Citrate. So we got citrate toxicity problems as well. All right. Any questions? Well, just remember what is in plasma, because remember, this is not the only condition where this is not the only disorder that will use plasma exchange. All other, this is an option for all other autoimmune disorders as well, not just myasthenia gravis. Okay, so we'll talk about this again later when we get to Guillain-Barré syndrome. Okay, that's another autoimmune disorder. So what are those four again in plasma? So plasma contains water, proteins, antibodies, and clotting factors. So if you remove them, could you have problems with all of those? Yes. Even though we replace it with somebody else's plasma, doesn't mean you won't have those problems. Okay. So how often? Again, the doctor decides. So you'll have what will be the effect of plasma exchange? Temporary reduction in circulating antibodies, just like in IVIG, temporary, okay, doesn't cure. So it's either daily, meaning 7 days a week, or every other day, depending on the patient's antibody levels. Any question? All right, let's finish up with the management. So surgery, of course, if this is thymoma, remember the the thymus gland is part of your immune system. So therefore, if you lose it, what's the consequence? Okay, your immunity will be compromised as well. But how many people have this as an option? Okay, only a few percentage of the myasthenia gravis population. Not everybody has the thymoma. Let's go to complications. Two most common complications, as we described earlier, is because the patient changes the dose of the anticholinesterase agent, could they possibly get too much? Could they also possibly get not enough? Yeah, too much or too little. Either way, this will result in a crisis. Let's talk about myasthenic crisis first. This crisis results from not enough. Patient is not taking enough of the anticholinesterase agent. The problem is, and the opposite, if you take too much, we call that cholinergic crisis. So cholinergic crisis, over medication, and what is myasthenic crisis? Okay, under medication. Okay. The problem is when you have a myasthenic or a cholinergic crisis, it's not always easy to tell apart because both crises result in extreme weakness. There's very few differences in the manifestations. You'll see that in the next paragraph, but not all patients exhibit those differentiating manifestations. Do you follow? Meaning not all patients have those distinguishing manifestations. So therefore, is it easy to distinguish? No, symptom-wise, signs and symptom-wise, it's not easy to tell apart. One is not enough, the other is too much. So how do we differentiate between the two? We'll get to that shortly. Let's look at the manifestations first. So we got a common precipitator here is usually what causes a crisis? An illness, something stressful, usually respiratory infection, surgery, pregnancy. So something stressful, okay, either traumatic or any other strong stressor, okay, that can precipitate a crisis. Meaning, what happens to your medication needs, medication requirements when you're under stress? It increases, right? Okay, so that's what will usually precipitate a crisis, meaning you're not aware that, oh, I didn't know I needed more of the medication. Okay, because are you aware that you're stressed? No, right? You're just stressed. Okay, sometimes that clouds your judgment, right? Meaning you're so stressed. Can you think clearly? No. So you're not aware that you are more stressed than usual. Not thinking that, oh, this requires an increase in my drug dosage. Okay. So when you have a crisis, remember, is breathing a repetitive muscle movement? Yes. So when they have a crisis, then the patient will have respiratory symptoms. They'll have respiratory depression, could go into respiratory arrest, requiring intubation and mechanical ventilation. So that will be required. We'll discuss the intubation and mechanical ventilation in a separate chapter next semester. Please take note that if, let's say, it's myasthenic crisis, which means did you have too much or not enough of the drug? Not enough. You would think that the treatment would require that we give you more, correct? That would be the logical thing to do, right? But what does this say here? Can you read it louder?
Cholinesterase inhibitors are stopped when respiratory failure occurs and gradually restarted after the patient demonstrates improvement in the course of therapeutic plasma exchange or IG.
Okay, now the reason for this is the drug actually causes the thickening of your secretions. Now, is that good if you're intubated? No. So because of this, if the patient is in crisis, either cholinergic, well, especially if they're in myasthenic crisis, we don't give them the drugs. Okay, we hold them because we don't want the secretions to be thickened. Yeah, because now the patient's airway will be compromised. So we hold them, we'll just treat them symptomatically until they improve, then we can restart the therapy. And last statement says, if the patient is intubated for too long, then we may give them a feeding tube. Because can they swallow, chew, and swallow? No, too weak. All right. So let's go to the nursing management. So what do you teach the patient? So everything mentioned here, so energy conservation, you teach them about how to take their medications. What are the strategies for the eye problems? We'll address them a little later. And then also the signs and symptoms of a crisis, either cholinergic or myasthenic crisis. Here's another QSEN alert. What is the advice here? When should they take the medication? So let's say I'm about to eat my first meal of the day. When should I take the drug? How much before? Okay, 30 minutes to 45 minutes, or at least, the most would be an hour. But I would take it maybe 30 minutes, 45 minutes before a meal, because do I need it during chewing and swallowing? Yes, I need it. That way, if I take it just before meals, can I finish the meal? No, the drug hasn't been absorbed yet. So I need to take it ahead of time, like 30 minutes, 45 minutes before a meal, I take it. So 50 minutes late there, now I can eat and I can finish my meal with enough energy to chew and swallow. Please read the individual strategies, okay, for energy conservation. I won't read them all for you. Let's go now to the including this paragraph. Okay, so here meal times. Again, how far from before a meal? Okay, 30 to 45 minutes. And of course, you sit upright. Okay, again, read those yourselves. For vision, as I mentioned earlier, these are the suggestions, recommendations on how to manage because what were the early manifestations again? Diplopia, ptosis, right? Yeah, so remember, eye movements are also repetitive. Okay, so it will also weaken that, right? And the swallowing, okay, chewing and swallowing.
Because of the mindset, they are probably less likely to pass the patient.
Well, this good thing about this will mostly affect skeletal muscles, except the diaphragm. Of course, diaphragm is a smooth muscle, but we didn't see any constipation symptom mentioned so far, right? None. So no, it doesn't affect the GI tract. Yes, again, the exception is the diaphragm. The diaphragm isn't really a skeletal muscle, but it is affected. All right, so here's the first crisis, myasthenic crisis. Now, what I mentioned earlier was it's hard to distinguish, right, between a myasthenic crisis and a cholinergic crisis. So when we talked about tensilon testing earlier, was the patient already diagnosed and therefore taking the drug already? No. So therefore, first scenario we discussed was patient came to the doctor with the symptoms, no diagnosis yet, so therefore no drug treatment. They haven't been taking it. So it was safe to do the tensilon, okay, because you either get a positive or negative, right? Now, the patient's already taking the drug. And the crisis is either myasthenic, meaning they're not taking enough, or it could be cholinergic, meaning they're taking too much. So we need to do a tensilon test again. Now, it will be safe if the patient has myasthenic crisis, because what is the effect? If let's say a patient came in with myasthenic crisis, respiratory depression, weakness, if I give them the tensilon or edrophonium, what will be the effect? It will improve the symptoms. Okay, the patient suddenly has a burst of energy. Okay, yeah, okay, it's myasthenic crisis. However, what if it was a cholinergic crisis, which means they've already taken too much? What will happen if I give them the tensilon? Patient will die right there. So when we're trying to distinguish whether it's cholinergic crisis or myasthenic crisis, and we're administering a tensilon test, we need an antidote. The antidote is atropine, which is an anticholinergic drug. Okay, just in case, what if it's cholinergic crisis? So therefore, what will be the response? Severity of the symptoms will increase. Patient could go into into a coma, okay, into respiratory depression. So we need atropine. Okay, so we need to give atropine just in case it's cholinergic crisis.
Would work also.
No, epinephrine will increase heart rate, but it won't affect muscle contraction. So we really need the anticholinergic atropine. Any question about that? Okay, so for myasthenic crisis, we know this is not enough drug. Do we give anticholinesterase agents? If it's a myasthenia crisis, do we give anticholinesterase medications? Did we? What did the previous paragraph say? Joanna? Why? It will increase the viscosity of the secretions. Remember, don't forget that paragraph says we temporarily hold, right? So how do we treat again? If it's myasthenia crisis, symptomatically here. So we intubate if necessary. We put them on a mechanical ventilator, chest physiotherapy, to help mobilize secretions. We suction the patient. All right, any question? Okay, let's go now to the cholinergic crisis. Oh, sorry. Okay, didn't discuss cholinergic crisis, but it'll be similar. But definitely, if it's a cholinergic crisis, do we give any anticholinesterase agent? Definitely not, because they already have too much of it. Okay, so supportive treatment as well. Okay, so we intubate the patient, put them on a mechanical ventilator, and then as soon as the blood levels of the anticholinesterase agents go back to normal, then we can resume treatment. Okay, any question on MG? Okay, take your first break.